I don't know if I'd call myself an expert in anything, but thank you for that very nice introduction. And I'd like to thank you guys all for being here today and to listen to me speak. I hope I provide you some meaningful information, and I would like some comments or feedback on what you guys are seeing in the field as well as what you're doing research-wise. So thank you for everybody at Minnesota for also inviting me. We've done a decent amount of work at Iowa State with PCV3, and I'd like to give a special shout out to all those at Iowa State that have helped me with this work considerably, including Dr. Jimenez-Larora, Dr. Pinheiro, as well as Dr. Pinheiro's postdoc, Gunn, and Dr. Jimenez-Larora's PhD student, Juan Carlos. So where are we going, and what's this journey going to look like? So we'll just do some really basic info for you guys in terms of PCV2, PCV3 that Dr. Rivero touched on briefly as well. What we have seen at the US ISU VDL in terms of case reviews and what we found it strongly associated with and what it looks to be causing disease. Again, this case review has been published, and so some of this data is a little old, but I'll confirm for you guys that we continue to see these cases. So again, just like Dr. Rivera says, it's not a one and done. We're continuing to see multiple cases come through the door on a weekly basis. What's it important in terms of a case definition? And what can we learn from these cases when you start to look back at the metadata that was provided by submitting veterinarians, the implications and applications of those, as well as where we went after we determined what it was doing in terms of research. Experimental inoculations that we've conducted, which have included 3 studies, as well as our virus isolation attempts. And then what we hope to do in the next few months as well. So PCV3 versus PCV2, again, just basic information. They are very similar. It's like looking from pig to pig, comparing those two. So you can see all of those right there. Very, very similar. PCV is very different from PCV2. It's a bit like comparing a pig with a calf. So don't lump these things, just like Dr. Rivera said, into the same bucket. And it does not appear theoretically or in real life that PCV2 vaccination does protect against PCV3 infection. So just because you're vaccinating your herd for PCV2, don't expect any implications on PCV3. So what have we seen in the cases that we've had over the past few years? We're seeing it associated with reproductive failure, perinatal infection, weak-born pigs. In our data set, that's a little old now. We have only 3 of these cases, so this is by far the least representative clinical presentation that we've seen, as well as growing pig cases. So when you look back at these cases that are being submitted by practitioners, they commonly refer to an uptick in mummies and stillborns. If they give a number, it's 5%. I don't know how accurate that is, but that was what they would say. And they're often commenting that gilts and low parity sows appear to be predominantly affected by this syndrome. So what that tells me, at least, is that we need to do a better job of acclimating our gilts prior to introduction into the farms. It's not just PRRS. You've got to acclimate more than just PRRS. You've got to acclimate to what's on your farm already before breeding. We do not see any evidence of PCV3 associated with abortion. And so for our definition of abortion would be not necessarily, we lumped mummies and stillborns, so if they're a full-grown 27 crown to rump length, they're going to go in the stillborn category. Abortions for us is more of a, they aren't viable at the time of birth. So what we saw for mummies and stillborns, we got all of these submissions. Their crown to rump length, again, 7 centimeters to 30 centimeters, and that will tell us that they're being infected somewhere around those days of gestation. So that's usually when the dam is likely viremic about that stage. So it's commonly detected in multiple litters or groups that are being submitted together. And the PCV3 CT values ranged in this case study from anywhere from 9.4 to 34.4, but in the case where it's a 34.4 or 30 or above, you'll also have a litter that will be in the 10s to 20s. So this is the commonly where we're seeing CT levels. So if we do a genome copy transformation, it's about 1.3 trillion in those fetuses, genome copies per mil of tissue homogenate, so it can obviously replicate at really high viral loads in those guys. And if you're looking at the average, it converts to about 1.7 billion genome copies per mil in those guys. So if we looked at those data sets, they would be negative for all other well-known causes of reproductive failure in pigs. Bacterial culture was no significant growth. And we did follow up with NGS on 16 pools. And 14 of those fetal pools just came back with PCV3. One of them came back with cytomegalovirus, and another one came back with torcotinovirus. So kind of our home run was in 2 of these cases. We had a myocarditis, and like Dr. Rivera said, if you see lesions in fetuses, it's it's incredibly uncommon to see lesions in fetuses. But here we go. This is regular heart. All that purple stuff shouldn't be there, so that's all inflammation. And then you have the same heart, and you can see that PCV3 is replicating in those cardiac myocytes. So we wanted to look at the impact of PCV3 compared to other known causes of reproductive failure in swine. And so again, this data is a little old. Here are the number of cases. But what's important to know about this is it comes from a diagnostic lab. So each and every one of these cases, how I did my data, they're singly positive. So this is a singly positive PERS case. This is a singly positive PCV3 case. But what's more important is not every case, at least that comes to the ISU-VDL, is tested for all of these things concurrently. They're probably all tested for PERS, but during this time, for sure, we weren't testing all for PCV3. So you have to look at the percent positive of what you're getting. So if you look at the percent positive, about 11% of those cases were positive for PERS and singly positive at a CT value of lower than 30. So I also screened that. So the CT value had to be lower than 30 to be included in this analysis. About 5% of cases were positive for porcine parvovirus and porcine circovirus 2, and about 13% of cases were positive for PCV3. So just a little note on reproductive failure and in general. If you're looking at averages, you are probably missing some things. If you look at a herd level average of 7 mummified fetuses per litter, but you really dig down into your data set and you see this and you decide to chase these are different, why are they different? If you look at your sows, you look at your gilts, these are actually the gilts that made up that data set. So you have to look at the individual sow level commonly to get a diagnosis. If you walk the barn and you see 3 mummified fetuses in a litter, I'm probably going to tell you that's abnormal. Something's likely going on. If you want to do diagnostics, you probably should. And talking to everybody, you know, they battle back and forth numbers of what's acceptable and what's not. But in general, what we've decided kind of at the VDL is you get 2 to 3 mummies, stillborns, probably definition of an affected litter. So submit the affected litter, and so definitely submit more than 1 of those mummified fetus. 4 to 6 fetuses are great. They did some really early work on PERS. If you just snatch a fetus here, a fetus there, a fetus here, you can miss it. It doesn't always infect each fetus at the same time. So it's really important to increase your diagnostic sensitivity by submitting more than 1 affected fetus per litter. And this is really varied by who I've talked to on the phone, but anywhere, so 5% hit the trigger for some practitioners to submit, while it was 10 to 15% for others. So this varies considerably on a herd level, what's acceptable. So perinatal infections, we've had 3 cases of weak-born and abnormal piglets. We actually detected it in these guys' brain a lot lower than, not a lot, but at considerable CT values compared to fetuses. And what we see in each and one of these cases was inflammation in the brain. So this is an area of gliosis. There's inflammation surrounding that vessel. And then you can see PCV3 replicating in the brain of that piglet. Concurrently, there was also myocarditis. This newborn was actually frozen, so that's why you have some artifact. But all this purple stuff should not be there. So that's inflammation. And then again, you have PCV3 replicating in the cardiac myocytes in those pigs. So again, if you look at what we can do without looking at experimental inoculations, I think that when you talk to pathologists, the closest we can get to causation is going to be a lesion with in situ. So growing pigs, we see 3 to 10 weeks. Commonly, they're 4 to 6 weeks old. Clinical signs do vary based on what you guys are submitting, anywhere from dermatopathy to loss of condition or sickly-looking pigs. Lesions at the cell level are distinctive, and usually the CT is in the low 20s. Again, last time I was on, I actually had a case in a newly placed 3-week-old pig with this syndrome or these lesions. So unfortunately, we have no good clinical case definition because it varies considerably with what you guys are seeing in the field. We don't know the number of % of pigs affected on effective farms, but it's probably low. Fortunately, in one of these flows, I got to follow that flow over time because they were doing a vaccine trial. And it just happened to be that they followed these pigs out to like 12 weeks, but they would resubmit pigs looking for a different agent. And the pigs that they picked, for some reason, always had this periarteritis thing going on. So again, just like Dr. Rivera showed you guys, so this is a heart, this is a vessel, and there's inflammation around there. And then this is the mesocolon with a bunch of inflammation surrounding vessels. And then PCV3. For some reason, PCV3 likes to replicate. It seems like it has a proclivity for the cardiovascular system, so it likes to be in smooth muscle or cardiac myocytes. So it's a pathogen of pigs. It causes clinical disease in a subset of pigs. It infects. It does not appear to cause enteric or primary respiratory disease or a loss of condition like PCV2. At least that's what we've found. And what's its impact? We really don't have a great answer right now. It looks like it primarily affects the fetal wastage in the United States. So I think, again, another note to acclimate the gilts to endemic agents that they may not have previously seen. So moving on to the meats and potatoes of this. So research, given that it looks like it's a pathogen of pig, we should probably know more about it, have some diagnostic assays to investigate it. So we went and we did some experimental inoculations. We were hoping for the development of histologic lesions, of course, as well as understanding infection dynamics and develop a serologic assay. During this time, we also performed some virus isolation. So unfortunately, we needed to do these research trials in CD pigs, which cost about $1,000 a pop. So sample size is really quite small. However, we did do it. So in this, there's a room here. These pigs didn't receive anything. They were strict negative controls. There was 3 of them. There was 3 pigs that just got KLH with incomplete Freud's adjuvant. If you guys aren't familiar with PCV2 models, this is what they commonly use as immunostimulant in PCV2 models for reproduction of disease. We gave PCV3 to the 6 pigs, as well as PCV3 and the KLH with incomplete Freud's adjuvant. And again, this is a room, so these guys were held separately from those. We took serum, nasal swabs, and fecal swabs at 11 different time points during the duration of the study. Well, I should tell you a little bit about what this was. So PCV3, we didn't have an isolate at that time, so what we did was we took samples from a fetal case and samples from a weak-born piglet case that had those really low CTs. They were submitted for NGS to screen for any other known pathogens. They came up clean, so then we filtered them. And it was a tissue homogenate that we gave to these guys. The CT values were as low as 8, ranged from 8 to 11. And those guys received that tissue homogenate intranasally as well as IM. So nasal swabs, we could detect it anywhere from 3 days until 28 days post-inoculation. CT values ranged between 26 and 34. Fecal swabs were really inconsistent, however, they were positive in a small proportion of animals. About half of the animals in the adjuvanted group with PCV3 were positive at 3 and 10 days post-inoculation, and our last positive was 35 days post-inoculation. So serum was much more interesting than nasal and fecal swabs. You can see that we got positives in all the PCV3 pigs at DPI 3, and that's where it peaked, and it continued out till the end of the study, which was DPI 42. And all pigs were positive at all time points with the exception of DPI 10, where there was one pig that was not positive. So clinical disease was not evident. Shucks. Tissues at necropsy, a lot of them were positive. We collected 12 to 13, depending on if it was a boy or a girl. And everybody was positive on the tonsil, lung, liver, lymph node, adrenal gland, nasal turbinate, as well as the testicle if it was present. A majority of pigs were positive in the brain, heart, kidney, thymus, and the CT values did vary. And what you can see is the CT values were the lowest in the lung, liver, spleen, lymph node, and nasal turbinate from all of those pigs. If you look at the capsid ELISA, which is the ORF2, you can see kind of a weak response only in the PCV3 adjuvanted group over time. There seemed to be something going on in the PCV3 group, but it fell right back down. So during this time, we also took those samples from the weak-born pigs and some of the reproductive failure cases and gave it to Juan Carlos. Unfortunately, at the IICVDL, we don't have a classical virologist that does virus culture on a regular basis. So luckily, we had Juan Carlos who was willing to give it a shot. And so we handed him a bunch of samples. One of the cases was a weak-born, actually 2 of the cases were the weak-born piglets, and one was a reproductive failure case. And so he took them out to different passages depending on the case. And in here you can see that on the lung from this perinatal case, he got it all the way out to passage 9 based on CT levels. And we confirmed this by IFA. So here, this is DAPI, and we used 2 different serums, so serum L and serum N from hyperimmune mice. You put it on the cell culture, you can see that it was positive, and then you just merge those 2. And so all that green is PCV3 infecting those cells. We did further confirmation with RNA scope. So just another way of demonstrating PCV3 replicating in virus culture. And he screened them as well by NGS at different passages. So now that we had a virus isolate, we decided to take it back into CD/CD pigs. And this time we had 6 controls, and then we had 8 that were inoculated with the PCV3 virus isolate. These guys only got 1 mil intranasal and 1 mil IM, as well as your KLH and incomplete Freuds. So days post-inoculation, you can see 1, 0, 1, 5, we couldn't detect it, and then the first day a pig pop positive in the serum was DPI 7, and by the end of the study, unfortunately at DPI 28, all pigs were positive in the serum. Our last study we did just to further evaluate our serologic assay, and so this wasn't meant to do, I should just tell you guys right off, I'll tell you later, to do anything other than to get known status samples. So we took pigs that were 13 to 14 week old CD/CD pigs. We actually took them from a different study where they had served controls and transitioned them into this project so that we could get more known status samples. And we just exposed all 4 of them to PCV3 with a KLH incomplete for its adjuvant. They got 4 mils intranasal, 4 mils IM of the virus isolate, and they were boosted 28 days later with that same virus isolate. And we just necropsied those guys, I think, last week, so some information is still pending. Didn't see any clinical disease, but they did develop viremia. Day 7 was and it's 3 out of 4 of them developed viremia. By day 10, everybody was positive, and you can see that the ELISA over time with it peaking at the end of the study, which was 120 days post-inoculation. So summary of CD/CD studies thus far. No clinical signs, unfortunately. There seems to be a prolonged viremia, at least in this model. I'm not entirely sure what's going to happen if you go out to the field, pull field pigs, and look at them over time, if they're going to have this really prolonged viremia. If you talk about 120 days with pretty considerable CTs in the 20s, 30s, like the mid-20s, I'm not entirely sure that that you would find the same thing in conventional pigs or not. CD/CD pigs are great at many things, and they can guarantee you many things. However, I'm not entirely sure that it's you can take that information and directly apply it to the infection dynamics in the field. Their microbiota is different, their immune response could be different, so I wouldn't say for sure that in the field you're going to also have a prolonged viremia in those guys. You can detect it in nasal secretions, and there's transient shedding in feces. So next steps for us is look a little bit more into the serologic assay. Looking at infection dynamics, it would be great to get into the field and really understand how it moves through an affected herd. Monitor interventions such as guilt exposure or vaccination. Really, reproduction of disease is what everybody's going for, not only for to better understand it, but also for vaccine efficacy trials. Looking at co-infections, maybe doing PRRS, porcine parvovirus. Again, if you guys are familiar with PCV2, which PCV3 is different, but PCV2, looking at seeing if that is of utility to getting those histologic lesions. If you're doing a growing pig CD/CD model, I don't know about the development of histologic lesions in those guys, given that we only held them for how long we held them. So it'll be really interesting to see if we can do the growing pig model. I would really like, and I think we plan on doing a sow reproduction model, which I think is really going to be the nuts and bolts of it. Seems like that's how it's impacting our herd the most is fetal wastage. So that's of keen interest to me. And then looking at, of course, vaccine efficacy trials. Everybody wants an answer if they think they have a problem. And vaccine in general is usually the go-to for that. I think we need some information on efficacies of what's available. And I hope that that information comes out in a timely manner. So do you guys have any questions or comments, insights of what you guys have been doing? Anything like that? Yeah.
I might have missed this, but did you say what cell line was used and successful for virus isolation?
So it's PK15. Yep, a PK15 cell line. Yeah.
You mentioned that there were no clinical signs following the experiment of infection. I assume that you have looked at the tissues to see if there were histological lesions. You have not mentioned anything about
so I would say for the tissue homogenate and the virus isolate, there are lesions. They are there. There's inflammation surrounding vessels. However, it's not one that I'm going to put up on this board and be like, look at this, it's fantastic, because it's not. And it can be pretty non-specific. And so I think we're waiting on some additional like RNA scope things to say, okay, we have lesion, that's mild, it's mild. And we have in situ to confirm that PCV3 is the important factor for that. So unfortunately, I think the jury's still out on all that, and I'd really like to see additional information to confirm that those mild changes are consistent with PCV3. Oh, no.
When we're investigating the clinical case, what is your recommendation for control samples, and what have you seen in control samples?
So what is your definition of what clinical signs are you seeing? Like, what's your case definition for your clinical signs? Are you doing fetal wastage? Are you doing growing pig? Both? So in terms of fetal wastage, it's really hard to have controls for mummies and stillborns. But for us, if you go out and you find a case definition of affected litter with 2 to 3 mummies and stillborns, and then you submit 4 to 6 of those from that litter, and you pool for a PCR, and you get a CT 25 and below, you probably have your diagnosis. And for controls, I'm not sure how you would do that. Fetuses shouldn't have anything in them other than host genome in general. They shouldn't be replicating a virus. So having something in the trillions or billions of copies is biologically significant in a fetus, especially if you're seeing it in stillborns and mummies.
So ask off of that. So you're telling me you're not necessarily seeing anything histologically on mummies or stillborns. You're going off of low PCR positive CT levels. So
in the 22 cases that were involved in the case report, 2 of them did have lesions of myocarditis with PCV. So you can see it. It's rare, and it's rare with PERS. For instance, I had a litter of PERS piglets submitted to me. There was 15, and I wanted to know how many do you actually see lesions in? It was 1 out of those 15 that and it was incredibly mild. And so if you guys are submitting 3 fetuses, 4 fetuses from an entire litter, it's probably unlikely that we're going to see lesions in those guys. Yeah? I don't know anything about transmission to boar semen or proof that it happens. However, I would say if you find a virus in the serum, it can probably be found in the semen, and then it's another jump to go, is it at an infectious dose to be introduced into a herd?
One more question? If not, I do have one question before I let you go. Maybe you covered this already a little bit, but some people have gotten really good at diagnosing PERS fetal death problems by sampling the sow and getting PCR positive results in the sow. What do you think about that approach for PCV3 in the absence of having the actual fetal samples?
I don't know if we know enough about PCV3 and its duration of viremia in a sow that had reproductive failure. Do you guys? What are your thoughts on that?
I don't think we have enough information, and I don't think we should be doing diagnosis of reproductive problems based on PCR positive on the sow only.
Yeah.
Right now, that's my approach, but
yeah.
I think we still need to learn a lot. For PERS, we know a lot more, but it's a different story.
Yep. Thank you all.
Thank you very much.